Để tiếp theo xin kính mời giáo sư Laurent Salomon tiếp tục báo cáo với chúng ta về khuyến cáo thực hành của ISO về vai trò siêu âm trong tiên đoán dọa sinh non. Xin kính mời ạ.
All okay, translators? Good, thank you. They had some rest, that's good. So they're ready again. We are going to talk about another very important topic in prenatal care and in obstetrics. That is the prediction and prevention of preterm birth. You all know that beside the growth restriction, preterm birth is a major contributor to morbidity and mortality. And we'll discuss about that now, and we will discuss about that again in Seoul in October, so please do come to Seoul for our World Congress. So I will mainly base this presentation on our recent guidelines from ISWOG again. These were led by Dr. Coutinho and Professor Da Costa. This was the working group. And so I have integrated all these guidelines into this presentation. And each time we will focus on a very important part of the guideline. I will stop on that slide so you will know that it is part of the ISWOG guideline. So basically, preterm birth is defined as delivery occurring before 37 weeks of gestation. It's a contributor to morbidity and mortality, and the prediction of preterm delivery is really the basis of prevention. Premature delivery may occur everywhere around the world. You can see that there are some differences in prevalence depending on the countries, but it's approximately around 10% of all deliveries all around the world, including in Vietnam, as you can see on this map. And basically another important fact is that the prevalence of premature delivery has not really changed over time. You can see over the past 2 or 3 decades, the prevalence basically has remained the same. So what can we do about prediction and prevention of premature delivery? Then you can act at 3 different timing in the pregnancy: before or early in the pregnancy, in the first or in the second trimester, and of course there are different settings where you will manage the risk of preterm delivery. It could be in an asymptomatic woman, but only with the short cervix. It could be in a symptomatic woman, a woman presenting with contractions. And it could also be in a woman at high risk of premature delivery, mainly because of a previous history of premature delivery or because she has a multiple pregnancy. So before an early pregnancy, not much can be done. You must only recognize what are the risk factors of premature delivery, which is mainly having had previously a premature delivery or having a pregnancy that is conceived with assisted reproductive technologies that may lead to multiple pregnancy, which are of course at higher risk of premature delivery. In the first trimester, besides trying to recognize this risk factor, what can you do? You can try to measure cervical length in the first trimester. There were many studies evaluating the relationship between first trimester cervical length and the risk of premature delivery. But there is an issue in the first trimester, which is it's very difficult to define exactly what is the cervix, because there is the isthmus and there is the cervix, and it's difficult to know where exactly is the internal os. And there are a lot of controversies about how to measure precisely the cervix in the first trimester. A few years ago, we defined quality control criteria for measuring the cervix in the first trimester, and these are shown on this picture. And you can see that there are various ways of measuring what is the cervix in the first trimester. This was reported in a publication by Oliver Kagan. And you can see that depending if you are to measure from here to here or from here to here, there will be a large difference. And also because the cervix is very curvy in the first trimester, it's not clear whether you should measure it with a curve or with a straight line. But basically, what you may keep in mind is that there is somehow a relationship between the measurement of the cervix in the first trimester and the measurement of the cervix in the second trimester. And of course, The longer it is in the first trimester, the longer it will probably be in the second trimester, and therefore it is somehow related to the risk of premature delivery. But the association, the relationship is really weak, and it's not strong enough to become a good prediction marker of the risk of premature delivery. So basically it's somehow related to second trimester measurement, but it's not really useful, and it's mainly used for research purposes. But based on large studies, it has been shown that there is a small relationship between the cervix in the first trimester and the risk of premature delivery. But again, it's not very useful in daily practice, so it's not recommended so far, except for research purposes, to measure the cervix in the first trimester. What about the second trimester? Certainly, cervical measurements from the second trimester onwards is very useful, and it's much more useful than digital examination of the cervix because it is more objective, it's more reproducible, it gives you a numerical results on which you can base your management, and it has better sensitivity and specificity than digital examination of the cervix. But of course, as always in ultrasound, if you want to do a measurement, you have to do it properly. You have to follow quality control criteria that are again summarized on that slide. You can refer to that slide. There are strict instructions for obtaining a proper measurement of the cervix, and there are quality criteria, just like with the nuchal translucency. If you are to measure the cervical length, you have to follow the quality criteria that are shown on this slide, and this is really important. So this is the first real guideline from our document, that cervical length measurement for the prediction of preterm birth should be used, but performed only by transvaginal ultrasound, not transabdominal. It works, but it does not work that well. So you should definitely use transvaginal examination to measure the cervix and to predict preterm birth. And you should use for your management the shortest, technically correct measurement of at least 3 cervical length measurements, and you should report this shortest measurement. And of course, you should follow strict quality control criteria, and ideally you should be certified by whatever organism as a trained operator for cervical length measurement, because it's not that easy to measure the cervix. Again, you must use the shortest measurement because there are changes in the cervix over time. And you can see, for example, the effect of having an excessive pressure on the cervix that will artificially increase the length of the cervix. And you can see that these are 2 different measurements obtained in the same patient just by changing the pressure on the cervix. So it's extremely important, and it's also extremely important to wait and to measure several times the cervix, because at the moment of a uterine contraction, the cervix may shorten, just as shown on this slide. This is again the same patient, same day, same examination, and you can see the cervix at 3 different times, and you can see how variable it is. And in a woman at risk of premature delivery, the cervix will tend to change according to this pattern. First, that will transform from this aspect to this aspect with an opening of the internal cervical os, and then it will open more and more, and then at the end it will be like that. So there is a change from a shape that looks like a T here to a Y here, then to a V, and then to U. And you can see from these letters that you can trust your vaginal ultrasound, and this is a way to remember these changes in the cervix over time. And again, it's important to repeat your examination during the scan, because there are changes over time in the cervix. And this is another example. You can see the same woman, you keep going with your ultrasound examination. You should not take a measurement instantly. And you can see here how the amniotic sac tends to get into the cervix and to shorten the cervix in this woman who is for sure at higher risk of preterm delivery. Of course, you should perform your cervical length measurements appropriately, just as we showed, but you should, of course, interpret your measurement according to other criteria. And these other criteria are the gestational age at which the measurement is taken, and whether there are symptoms or no symptom in the woman, and of course, where there is any previous history of preterm birth in this woman. First, interpret your cervical length measurement according to gestational age. It seems obvious, but having a cervical length of 20 millimeters doesn't have the same value if you are 18 weeks of gestation or if you are 34 weeks of gestation. And you have to remember that physiologically, the cervix tends to reduce in length over gestation. And this has been shown by different teams. You can see that there is a shortening of the cervix over gestation, and that therefore the risk of premature delivery depends on the length of the cervix, of course, but also on the gestational age at which the measurement was taken. And the shorter the cervix and the earlier in gestation, the higher the risk of preterm delivery. It is very logical, but it is very important to keep that in mind. Second, you should adjust your cervical length measurements to other markers such as clinical symptoms. In a woman presenting with uterine contractions, it's extremely important to measure the cervix to know what is the exact risk of premature delivery. It is the best marker of imminent delivery. And of course, the shorter the cervix, the higher the risk of delivery within the next 48 hours or within the next 7 days. And this will be extremely useful to triage the patients between those with contractions who require to be hospitalized to get steroids and to prepare for delivery, from those with contractions also, but that you can safely send back to home. So this is really the cervical length that will help you differentiating between these two populations. So this was said again in the guidelines. This is shown on this slide. In women with singleton gestation and threatened preterm labor between 22 and 34 weeks of gestation, transvaginal ultrasound cervical length measurement is recommended to assess the risk of preterm birth. If it is above 30 millimeters, the woman can usually be discharged with precautions. If it's below 15 or 20 millimeters, then usually you should admit the patient for steroids and tocolysis according to local protocols. And in between, it will depend on other markers or on your local policy. So this is again the same thing summarized graphically, but it's the same recommendation that you will be able to look at on your slides. What about the opposite situation? A patient with a short cervix but no contraction. It's just routine screening. We know that having a short cervix is an independent marker of your risk of having a premature delivery. It's a very good marker, and nearly 50% of women presenting with a cervix below 15 millimeters will deliver prematurely. More generally, the cutoff of 25 millimeters can be used as a single and simple cutoff for the initiation of measures to prevent preterm birth in a woman with no other symptoms or risk factors. So it's very important, this cutoff, 25 millimeters, it's enough to decide to initiate measures to prevent preterm birth. What are these measures that you can initiate? Pessary. Why not? There were many studies about pessary in the literature, but overall, it does not seem to be very efficient. There were many studies, including one big one by the team of Kypros Nicolaides. As usual, everything was mixed up into meta-analysis and review, and overall, the effect of pessary does not seem that good. So the recommendation is that current evidence does not support the use of cervical pessaries to prevent preterm birth in asymptomatic patients with cervical length below 25 mm outside of research protocols. So that's clear for pessaries. What about cerclage? There were some studies suggesting that cerclage may be useful to prevent preterm birth in women with a short cervix, including an old randomized study which showed that it was beneficial to women with a cervix below 15 mm. Again, it has been summarized into meta-analysis, reviews, etc. The Cochrane library says that it is probably useful to prevent preterm birth, but the problem of cerclage is that it's quite invasive. It's a bit more complicated to perform a cervical cerclage. Whereas there is a treatment that has demonstrated clear benefit to prevent preterm birth that is very easy to apply, which is progesterone. Progesterone is definitely useful to prevent preterm birth in women with a short cervix and no contractions. Many studies, all in the same direction of a benefit of progesterone in this population. First study published in the New England Journal of Medicine, randomized study that showed that in women with a cervix below 15 mm at mid-trimester scan, progesterone would reduce the risk of premature delivery of about 40%. 40% risk reduction with progesterone. Same results in another randomized study by Hassan, published in the Ultrasound Journal more than 10 years ago. Again, a reduction of around 40% of the risk of premature delivery. And all the literature is going in the same direction, including meta-analysis and review of the literature. And you can see that altogether, the risk is reduced again by around 40%. It was shown as well when using all the most recent studies, including one that was called the Optimum study, which did not show a benefit of progesterone. Even if you include this study in the overall literature review, there is still a clear benefit of progesterone in reducing the risk of preterm birth. And it was also shown in those kind of studies, which is a before and after study in a center where they used not to use progesterone, and then they changed their practice and start using progesterone in women with a short cervix, and they observed a reduction in the rate of premature delivery. So there is a clear effect, but of course, as always, you will need to screen many women and then to measure many short cervix and then to give progesterone to many women before you can see a reduction in the risk of premature delivery and to avoid one premature delivery. But the number needed to treat, as we say in statistics, is basically within the same figure, the same order, than, for example, when you are using steroids to prevent respiratory distress syndrome at birth. So clearly, now altogether, it seems that we have enough evidence to offer a universal screening for the risk of preterm birth in all women. This is why now most international recommendations suggest that we should measure the cervix on a routine basis in all women at mid-trimester scan, because it's not a measurement just to do a measurement. In case of a short cervix, you have something to do, which is to give progesterone to efficiently reduce the risk of premature delivery. So that's very important. And again, cervical length below 25 mm can be used as a cutoff for the initiation of measures to prevent preterm birth in asymptomatic singleton pregnancy, irrespective of risk factors. If you are following well this presentation, you may have noticed that it is the second time that I'm showing you the same slide, because it's really important. you can now offer universal screening for the risk of preterm birth because there is something to do. And again, what it is you should do in case of a short cervix with a woman with no symptom and no other risk factors, the restriction of baseline physical activity is not recommended. It doesn't change anything except that it may increase your risk of thromboembolism. So it's useless to reduce the activity. But what is useful is to prescribe progesterone before 24 weeks and up until 36 weeks in all women with a short cervix. Once you've started progesterone, you may still follow up the cervix because cervical cerclage can still be considered in women with a cervix that shortens below 10 millimeter, even if they are already under progesterone regimen. So it's still useful to look at the cervix in a woman with progesterone. Again, this is a summary of what I've just said, shown on an algorithm that may be useful. And again, remember that you should measure the cervix at the mid-trimester scan in order to give progesterone to those women with a short cervix. What about patients with a history of preterm birth? That is something that occurs frequently. Of course, it's a strong risk marker of premature delivery. Of course, the number, sequence, and weeks of gestation of previous births all affect the risk of recurrence. But basically, in half of preterm births, the mother has no previous history of preterm birth. So that will not help in many situations. Basically, what you have to remember is that in any woman with 3 or more previous preterm birth, you should go straight to cervical cerclage at the beginning of pregnancy. So if you have 3 or more preterm birth, you should go straight to cerclage. In women with only 1 or 2 history of preterm birth, you should offer progesterone, and we will see that, and you should look at the cervix from 14 or 16 weeks of gestation, and keep looking at the cervix every 2 weeks to offer cervical cerclage in women with a shortening of the cervix. So basically, although evidence is still conflicting, in women with singleton gestation and prior spontaneous preterm birth, treatment with vaginal progesterone every night from 16 to 36 weeks should be initiated. This is my belief, or a simple surveillance and treatment for all women with a cervix below 25 millimeters. In women with singleton gestation and prior spontaneous preterm birth, transvaginal cervical length measurement screening should be offered every 2 weeks, starting from 14 or 16 weeks, up until 24 weeks, if the cervical length is above 30 millimeters. If it's between 25 and 30, then probably you should repeat the measurement within a week. In women with singleton gestation and prior spontaneous preterm birth who are on progesterone and who have a transvaginal cervical length measurements below 25 millimeters, then an ultrasound indicated cerclage may be recommended. And as we've already said, follow-up cervical length measurements should be considered after initiation of progesterone because you must still offer cerclage in women with a shortening of the cervix under progesterone. And there is a lack of evidence regarding cervical length follow-up after cerclage placement. So this is the resume of what I've just said about the follow-up of women with a previous history of preterm birth. Last but not least, twins. What to do with twins? Well, until recently, we had absolutely nothing to offer in twins to prevent the risk of preterm birth, until some meta-analysis suggested that progesterone could be useful again in twins. But not in all twins, and there was a nice study performed by the team of Kypros Nikolaides again about the use of progesterone in twins, probably progesterone is useful in twins with a short cervix. And again, probably that the cutoff of 25 or 30 millimeters is again the good one to decide which twin pregnancy should be treated by progesterone. So cervical length measurement is the preferred method for screening for preterm birth in twins. 25 millimeter is again a pragmatic cutoff between 18 and 24 weeks of gestation. Prophylactic use of progesterone is not recommended for the prevention of preterm birth in unselected twin pregnancy, but it is recommended to consider the use of progesterone in twin pregnancy with a cervical length below 25 millimeter. History indicated cerclage is not recommended. Combined strategy based on cerclage, antibiotics, and tocolysis may be considered in twin pregnancy with dilated cervix before 24 weeks. The prophylactic use of cervical pessary is not recommended. And there is conflicting data about the use of pessary in twin pregnancy and a short cervix. Last, there is insufficient evidence to support the benefit of cervical length measurement in symptomatic women with twin pregnancy and preterm labor, or to suggest optimal cutoffs to guide clinical management. Last but not least, I would like to remind you that there are some applications that are available on iPhones or Androids that may help you assessing the risk of preterm birth based on maternal characteristics and cervical length. This is an example of such apps. There are many of them that are available on the internet. And again, please do have a look to our guideline for more explanation on what I've just shown to you today. Thank you very much.